Hey everybody, it's Dr. Brace here. It's the last Facial Plastics Friday for summer of 2024. It's hard to believe we're already at the Labor Day long weekend, but here we are. I spent the day today at Guelph General Hospital operating. Yesterday we were at Guelph Surgical Suites operating. And today I had 2 nasal reconstruction cases as well as some trauma cases to do. But what I want to talk about today is the use of cartilage in nasal reconstruction. The nose itself is made of cartilage and bone in terms of the structure. The upper third of the nose is bone. You can feel your own nasal bone and come down. You'll feel the very edge of the bone there. And right there, that bony edge connects to something called the upper lateral cartilage. And where they connect is called the ranion. And then the upper lateral cartilage connects to 2 paired domal cartilages or lower lateral cartilages, and they attach in an area called the scroll area. Your septum is the middle wall right in the middle of your nose, and it sits on a bony nasal spine which continues backwards in your nose as the maxillary crest, and at the back of your septum, this is all cartilage in the front. Your septum then attaches to a bony septum, your perpendicular plate of the ethmoid and your vomer. And so your nose is made up of cartilage kind of on the outside, bone at the top, bone at the bottom, and bone at the back. And when somebody has a nasal deformity and they can't breathe, it's usually because there's either a bony deviation or cartilaginous deviation inside their nose from the septum being broken, or the internal nasal valve where the upper lateral cartilage attaches to the septum. It creates a valve. If you can imagine, the septum is sitting straight like that, the cartilage is attaching, and in between those two, that little triangular space, when you breathe in, you create a negative pressure or a vacuum. It can be weak, it can be scarred, it can be deformed, and you can get a collapse where you go, and then because that collapses inward like that, and that's the area of maximal airflow when you're breathing, if it collapses and you feel like you can't breathe. The nostril aperture is called the external nasal valve, and you can also have a weak nostril aperture or weak nasal valve. And when you breathe in here, have this collapse, and that's called external nasal valve. And then you could be weak in between the two of them, and that's the intervalve area, and you can have an intervalve collapse. And so when we are doing reconstructive surgery or functional septal rhinoplasty to help somebody breathe better, often the septum is either broken, deviated, twisted, or has been removed or partially removed from previous surgery where somebody's attempted a septoplasty to try to make someone breathe better. And the great irony of this is if you have a weak nasal valve and you increase the airflow by removing a septal deviation, you increase the negative pressure, which increases the collapse. And so paradoxically, it's not uncommon for someone to have a septoplasty and have worse breathing afterwards because the nasal valve wasn't addressed. So I say all that to say, often in these septal rhinoplasty surgeries, we need cartilage. We need cartilage to rebuild the septum. We need cartilage to lengthen the septum. We need cartilage to put in spreader grafts, which will spread open the internal nasal valve. We need cartilage to place batten or strut grafts to support the intervalve and the external nasal valve, or even cartilage for rim grafts to support the nasal valve. Sometimes we need a little columnar strut, something to support the tip. And if you don't have enough usable, meaning straight, unfractured septal cartilage, then you need to get it from somewhere else. If the septum is not available for whatever reason, we have 2 options for autogenous cartilage or cartilage from the patient. You can take it from the conchal bowl, which is right here, and you can do this 2 ways. I like to make an incision right inside the antihelical fold here, lift this skin up and steal the cartilage from there. That does not change the way your ear looks. It does not change the way your ear functions. Some people like to do it on the back of the ear, kind of like an open otoplasty, and harvest it that way, and that hides the scar behind the ear. A little more bleeding, a little more work, a little more tenderness I find from that. So I find this scar is basically invisible once it heals, and it's a little easier access and more comfortable for patients, and that's why I do it that way. The other option is to go from the chest, from the rib. And so I usually harvest from the right side, from the 4th or 5th rib, and where your breastbone or your sternum connects to your rib, that is cartilage. It does get ossified or become bony as people age. So you could run into a problem where somebody is, in their 60s or 70s and they have no usable cartilage from the ribs anymore, and maybe they've had surgery and they've already had their ear cartilage taken. Then in that situation, you have to go to cadaveric rib or take rib from a tissue donor. And so all that to say, rib and ear are very, very common sources of cartilage in my practice because I do a lot of revision rhinoplasty and reconstructive septal rhinoplasty for breathing issues. And I was fortunate enough today to have both cases. I had a rib graft case and an auricular or ear cartilage case. And I'm going to show you what those cartilages look like here and how we use them. So if you are squeamish, stop watching now. But if you want to see what rib and ear cartilage looks like in the OR and how we place them and how we use them, and then this part is for you. Otherwise, everybody have a great Labor Day long weekend, and we'll see you next week.